All right, guys, let's get started. It is 1 o'clock. I appreciate everybody that's here, for taking time out of your day to come learn a little bit about radiology. I really appreciate it. Just a couple uh, house cleaning things here. Um, the study guide that I put together is basically everywhere. I sent a box yesterday to Lynette in Boise. She's going to distribute those between Boise, Burley, and Haley. I still need to send a box to Sierra up in northern Idaho, but besides that, everybody should have them. So they should get there Friday, is what they said. So anyway, be on the lookout for those. It's a nice help to go along with this class. It kind of goes hand in hand with the study guide that I wrote. So anyway, it's on its way. So like I say, I appreciate you guys being here. Let's get started. And I don't think this is going to be a real long one, but there's some good information in it. So just as soon as this is ready, we'll get going here. All right, Ms. Kate, can you see that okay?
Yes, we can.
All right, good. Hey, so LSRT study group number 11. So LSRT stands for Limited Scope Radiologic Technologist. If you're wondering what that stands for, that is actually the acronym for the test you're going to try and take here. You'll be known as an LSRT, which is cool. Today we're going to talk about image identification and evaluation. But first of all, we're going to review a little bit from last week in case you haven't been able to get on the radiology group and watch that or attend. Just so you know that I do post every one of these classes to the radiology group on the Sterling Intranet Hub. Now they are also on my YouTube channel. If you're unable to get on the Sterling Hub, it's the Wyoming X-ray guy, the YouTube Hub thingy channel. Anyway, just so you know, it's out there. If you guys want to learn about radiology and follow along with what we're doing, it's out there for you to view. And I'm also available for questions or anything that you might have. So anyway, last week we talked about image acquisition, and what image acquisition is, and we all pretty much know what that is now. It's when the patient is exposed to a beam of X-ray photons, which then interacts with the tissues and structures inside of your body, which results on shadows on digital image board or film analog image emulsifying screens. You just have to know what that is. We don't do a lot with analog stuff, so we don't do anything actually. Anyway, tissues with higher density like bone absorb more X-rays. Thus is going to appear lighter on your X-ray film, where tissues with low density, like soft tissues, lung tissue, stuff like that, absorbs less energy. So more energy is going to make it through to the image receptor, and your image is going to be darker. Okay, that's what image acquisition is. It's also called image attenuation. So we talked about different types of image receptors. The first one is an analog, which is a cassette that you place a emulsified film inside, and you shoot your X-ray. It goes through there, and it forms a latent image on that film. And then you have to use chemicals and heat to make sure that film. Sorry, my brain is not working. Interacts with the film emulsion, and it leaves a latent image. You put it in the image processor, and voila, you've got an X-ray film. We're lucky though, because we don't have to deal with that. We are completely digital radiography, completely DR, which is really, really nice. CR would be okay, but we're not even CR, we're DR. We're living high on the hog here. So with CR, it uses an IP plate, and you actually have to put that cassette in a laser reader, and it will read that image and put it on the screen for you. Now, digitally, we skip all that, okay? We take our image and it's an electrical signal, and it's digitized and displayed on the computer screen for us. It's really nice and really handy. So digital images are processed using a software enhanced contrast, reduced noise, and corrected artifacts. Okay, our software does a lot of work for us, is what that is saying, basically. It takes that image from when we push the button to the computer screen. It does a lot of different things with that image. It corrects artifacts sometimes. It can correct motion. It makes your contrast brightness as good as it possibly can within its algorithm. And that's awesome. You know, we don't have to do a lot of post-processing stuff on our images, just because our API, our techniques are set up in the computer really well. So unless you've got a bigger patient, and then you'll have to make some adjustments. But we've got it pretty good, pretty awesome. So we also talked about factors that affect image quality, and there's a lot of them. You wouldn't think about it, but you would think that it's just your technical factors, but there's a lot more that goes into that can affect our image in a bad way. SID, source to image distance, OID, object to image distance, and focal spot, both effective and actual, they all affect our image quality. You know, how close do you have that patient to the image receptor? If there's space there, we're going to have some magnification. That's called OID. Okay. Now, the source to image distance, you know, we usually shoot our images at 40, right? Some we shoot at 70, 72. If we have some OID, we're going to increase our distance to help alleviate that magnification that we might get, i.e. a chest X-ray. We don't want magnification on the heart. We want that heart to be actual size. That's why we shoot them at 72 inches, because the heart actually sits back from the image receptor about that far. So we need to combat that with our distance, our SID. KVP, mass, and exposure time, those all affect images. The size of the patient, density of the patient, BMI, positioning, all those things have an effect on our finished product. And that's what we're working towards you guys knowing what you need to do if you have a bigger patient or a smaller patient, how to reduce technique or increase technique. And going forward, we're going to get more and more into that, and it's going to make sense to you, which is awesome. We talked about spatial resolution, the ability of a system to differentiate between two nearby objects, or measure the smallest detail that can be distinguished in an image. And we want good recorded detail on our images. And I know sometimes that's not possible, but we want to be able to see the intricacies of each X-ray. If there's something there that's going to help us diagnose what's going on with the patient, we want to be able to see that. And that's what makes X-ray so important. It's a huge cog in the medical machine. Without X-ray, we wouldn't be able to diagnose a lot of things. And it's our job as X-ray operators to give them the best possible picture to diagnose with. And that's what we're working towards. So distortion, we talked about shape distortion and size distortion, you know, the spatial relationship between structures on an image, how we can make something look bigger or smaller. We've talked a lot about collimation, how more collimation can lead to better pictures. Patient motion, voluntary and involuntary. They are involuntary. There's not a lot we can do with that, except for really shorten our image times, where our pictures are just short and sweet, and that'll help with the involuntary movement. But the voluntary, we can actually absolutely work with. Artifacts, you know, try to keep metal objects off the film if possible. We don't want to obscure anything that we need to see that we can't because there's some sort of necklace or something in the way. We also talked about the anode hill effect. That's the variation of intensity of your X-ray beam, where at the cathode end, where our electrons are developed and sent over to the anode, once it hits the anode plate, the cathode side is going to be a little bit stronger. Our beam is going to be a little bit stronger, where on the anode side, where the electrons are absorbed, our beam is going to be a little bit weaker. And basically all you need to know about that is your image intensity is stronger at the cathode end and weaker at the anode end. And we can use that to our advantage. If we have a body part that's thin on one end and big on one end, you can put the big end on the cathode side, and that'll help even out your image a little bit. Tube angles, patient angles, they all can affect our image. So that's kind of what we talked about last week. So let's move on to image identification today. Now, all this stuff is fairly easy, and it's important that we have these things on our images. So legal considerations, what do we need to include on any image that we take? Patient data. I've got an example coming up here. What do we need to put under patient history? So what happened to the patient? When did it happen to the patient? Where they are hurting? What region of interest is that? Symptoms, whether they have injured this body part before, any previous injuries to the area. Patient's name, date of birth, and patient MRN. Okay, those are all very important. Date of the study and the ordering provider. That's one thing that I've noticed that some people aren't doing, is they're not putting who's actually ordering the image. We need to make sure our ordering provider is on that somewhere. Okay. Examination information, what body part are we imaging? So what protocol are we using, whether it's a forearm or a wrist or an elbow. We need to pick the right protocol as to what the doctor ordered and giving the images that protocol calls for. Okay, very important. Let's see, what anatomical sides are we imaging, right or left, bilateral, whether we're imaging the patient upright or supine, what projection we're using. Projections are the way that the X-ray photons go through the patient, whether it be posterior to anterior or anterior to posterior or an oblique view. We need to make sure that that's noted on the image that we're taking. And there's actually, like on abdomens and chests, there's a big difference between supine and upright. You can see things on the upright that you can't see on the supine, and vice versa. So it's really good that we add that. You know, like a chest X-ray, something we know that that's probably upright, and if you don't put upright on there, it's not the end of the world. But if you're doing an abdomen and you do it upright, make sure you put the upright on there. And this is all done post-processing, so it just makes it easier. You just have to click the upright button and put it on the film. Okay, easy peasy. It's just common courtesy for the radiologist and the ordering provider to know whether that was upright or supine and what side of the body is what. Okay, I just wrote here, more information is good. Any help you can give the reading provider, the better off you're going to be. They like information. So here is a image that was taken, looks like in Idaho Falls last week. Very, very nice lateral chest X-ray. So whoever took this, great job. But I just wanted to put this on here to show you some of the stuff. Now, I've omitted the name just for HIPAA reasons, but the medical record number is there. The patient's age is there. Okay. The date of the image is there, date and time, and when the film was acquisitioned right here. And we've also got a history right here that actually shows up on the film, which is nice. And they've done a good job telling us what's going on with the patient. Okay. Now these stuff in the bottom corners, you know, they're just legal stuff. Where this image was taken, whether there was a zoom involved, and the W and L, that's your window or width and level rates. Okay, so if you were to change the contrast of this image, your L and your W are going to change. So this image right here, the way it's constituted, it is at a width of 4096 and a length of 2056. Okay. Anyway, and down here it just says what we're imaging, which is the chest, left lateral. Okay. All right. Anyway, good job on that image, whoever did it. We talked a little bit about image evaluation, the EXI number or the S number that comes up on your image when you take your image. And like I said before, it's just a number that's put there by the vendor to let you know where this image is exposed at what range. It also helps us depict what kind of exposure the patient is getting. We don't have to worry about a lot about these numbers other than knowing what they are and also knowing the parameters in which our images should be falling. Okay, so I think that we're probably, like for the Paxis units, which most of us have, I think it'd be a good idea to have these posted by your image machine. That way you guys can kind of keep track of where your images are exposing and if they're within those limits. And like I said last week, if they're not, it's not the end of the world. If your image is diagnostic, it's diagnostic. But if those are falling within those parameters, good on you. That's awesome. So here's a name or a word you're going to hear a lot, and it will show up on a test at some point. It's called quantum model, okay, or quantum noise. Just remember quantum model. This is random noise on a radiographic image caused by fluctuations in the number of X-ray photons reaching the detector, resulting in grainy or sand-like appearance. Okay, so know what that is, know what quantum model is, and here's an example of what quantum model looks like on an image. And I know you've all seen this. I get questions about this a lot. What's going on with my image? Why does it look grainy? Why does it look sandy? And it's actually quantum model. There isn't an answer to that. So it makes it difficult to see details on the image, especially if that image is underexposed. So you'll note the picture A right here. You can see the graininess, the blotchiness, the sandiness of the image. And as what happens here is this is underexposed. There's not enough X-ray energy to completely pass through the bone or the soft tissue, and it's causing graininess, which is called quantum model. Okay, now you look over here at the image on the B, where they probably increased their mass by 2 or doubled their mass, and depending on the range of unexposure, you'll need to quadruple or triple or quadruple your mass. But most of the time, especially on an extremity image, if you double your mass, it's going to take care of that quantum model for you. You can see the difference in the image quality here, where the underexposed one is really grainy. The one on the right is nice and clear. You can see good bony edges. You can see bony cortical really well. It's a nice image. But that is quantum model. Just make sure you know what that is and how to see it on an image. You'll see these a lot on chest x-rays or abdomens or pelvis a lot, just because they're bigger body parts and there's a bigger chance that you're going to underexpose. If that does happen, your image comes out really light, really grainy, you need to up your mass technique by at least a factor of 2, if not 3 or 4. So anyway, cool. That's quantum model. Hey, so identification markers, it's like we're beating a dead horse, but we need to make the effort to use our right and left markers. And I'm guilty of this. I get going and I'll forget to put a marker on there. I'll just do it post-processing, but that can come back and bite you in the behind. I think that we should use our left and right markers. If you don't have markers in your clinic, let us know, we'll get you some. Okay, just mark the side of the body that you're doing with those markers, and that way you're never going to have an issue. Placing markers, right and left markers pre-exposure could get you out of a bind when your imaging comes across non-anatomical, which we'll talk more about. But so say you take an abdomen x-ray, right? And you forgot to put your right or left marker on there. Now the image comes up upside down, let's say, which happens sometimes. You don't know which side is right and which one is left. It can really put you in a bind. Unless you can see the side that the heart on, it's going to be really hard to tell. Sometimes you can see the liver and a stomach gastric bubble to help you, whether that's right or left. But it's always a good idea to put your marker on before you take the image, okay? That way, if it comes upside down and sideways, you'll know which side is right and which side is left. And you can put the marker on there post-processing. We're going to talk a little bit about anatomical position today and making images look the way they need to look when they come out to the doctor. So anyway, use your markers. Fortunately, these markers can be added post-processing if you forget your right or left markers. Anyway, markers such as upright, PA, AP, supine, oblique, anything like that, you can put those on there post-processing. You know, we don't have markers that say PA or AP, or they do exist, but we don't have them. Just know the projection that you shoot that image, and once that image comes up and it looks correct, and hopefully you've got your right and left markers on there, you can go in and add an upright or a supine, whether that is a PA picture or an AP picture. You can do all that post-processing before you save the image. Once you save that image, it's done. You can't add those things. So just get in a good habit of when you take a picture and it pops up on the screen, make sure that image has all of its identification on there before you hit save, okay? Anyway, so regardless, all images have to have an anatomical marker on the image, and that's the law, okay? And I've got some examples of that coming up. Also, all images must be annotated anatomically correct, which we're going to talk about. Okay, so image evaluation and hanging protocols. Now, when you see hanging protocols, that is the protocol that is put in place to hang that image in front of you. What does that image need to look like on the computer screen when you save that image, right? Okay, so here's a few tips for you. So fingers tip. Okay, fingers. Okay, fingers. For the hand and forearm, your fingers should be up. So if you're shooting a finger, a hand, a wrist, or a forearm, when that image comes up on your screen, those fingers need to be up. Okay, and I don't know how else to explain that. It needs to be up and it needs to be anatomically correct, okay? And on your wrist or forearm, there's things you can look for so you know which one your radius and which one your only is on the screen. And that's going to tell you how that image is going to have to be annotated, and we'll talk more about that in a little bit. So just remember, fingers, hand, wrist, forearm, the fingers need to be up when the image is finished on your film. So if you take a picture and those fingers are pointing sideways or down, you know you've got to turn that picture upright. There's buttons that you just hit and it turns it for you. And then you need to make sure that that's a right hand or a left hand, right? Anyway, that's why it's a good idea to use your markers. So shoulders, humerus, elbow need to be hung from the shoulder, okay? So say we shoot a humerus, and it comes up and dang it, the head of the humerus is down on the bottom of the film. What do? Okay, we're going to turn that humerus up so it's hanging from the shoulder, okay? Same thing with elbow. The humerus needs to be up. The proximal radius and ulna need to be down, okay? And the elbow right in the middle. So I hope that makes sense. So shoulder, humerus, elbow, you hang them from the shoulder. Fingers, hand, forearm, wrist, you hang them from the fingers, okay? So femur, knee, tib, fib, and ankle. So anything below the pelvis up into the foot, you're going to hang from the pelvis. Okay. It needs to look anatomically correct in front of you. You're not going to hang a femur upside down and have the pelvis down here and the knee up here. It needs to look like that skeleton is standing there in front of you. Okay. Chest, abdomen, pelvis are all hung in anatomical position. Now I've got a little anatomical position dude over here, Mr. Skeleton. He is in an anatomical position. Now, if you, like, say you shoot a shoulder and you know that that needs to look anatomically correct and it needs to be hung from the shoulder, look at your guy over here. Does that image look like your image, or is it upside down or backwards? Okay, so you know that you shot a right shoulder and it comes up and it's turned and it looks like a left shoulder. Okay, you look at your skeleton dude. Okay, now that looks like a left shoulder, but I know it's a right. So you just need to flip the image so it looks like a right shoulder. Okay, I hope that makes sense, and we can go over this again and again and again. I know this is kind of a hard concept, but it is important. I know that it drives radiologists crazy when they get a forearm or a hand that's upside down and skittywampus and backwards. We just need to make the effort to make that picture look good for the radiologist. It makes it easier for them to read, and it makes it more diagnostic, believe it or not. And I know some of you might say, well, as long as the image is there, that's great. And that's great when you're starting out. But make an effort to make those images look the way they need to look. And it all starts with our anatomical position skeleton dude right here. Okay, make sure that image looks like that does when it's looking at you. Okay, minus feet and fingers and wrists and forearms. So your wrist, fingers, hand, and forearm are all hung from the fingers, right? Where your toes and your foot are hung from the toes. So if you got your foot right here and you bring your foot up in front of you, that's what it needs to look like, with the toes straight up. Okay, and whether it's right or left, you can see whether your foot looks like that foot. You know it's a right, and it looks like a right. I know that's a lot, guys. I'm so sorry, but if you have any questions about that, please reach out. And I would suggest getting a skeleton dude, just a picture of a skeleton dude in your image suite. That way you can look at that and make sure that your image looks right. Okay. Sorry, that's a lot. So we're just going to go through some images here for the last little part and look at incorrect and correct. Now this is the hanging protocol that I'm talking about here. We're not looking at contrast, brightness, density, anything like that. We just want to tell whether the image is hung correctly, right? So we take our hand image. This is a nice hand x-ray, and it pops up on the screen and it looks like the one on the left. Okay, now we know that this is a right hand. We took the image, it's a right hand, and it comes up backwards or upside down. Okay, what do we do? First of all, there's no marker on here. First mistake, but we can change that. We can put a right because we know it's a right. So we're going to look at this image on the left. We're going to hit the button that says turn. We're going to hit that button. Most of these computer systems are touchscreen. It's really nice. And you can turn that image so it looks like the one on the right. Okay. Now, like we said before, fingers, hand, wrist, forearm are all hung from the fingers, right? Here we are. We're hung from the fingers, meaning it's like somebody's grabbing the top of the finger and hanging it there in front of you, right? And it's a right. So if I put my hand out here and look at that, is this my right hand? Yes, it is. And it looks just like that. So it's correct. Okay. If we put our hand up here and it's supposed to be a left, it's going to look completely different. Okay. So you're going to have to flip that image. Okay. So just pay attention when your image comes up post-process or after it's been processed and it's upside down or backwards. Just make the effort to flip that right side up, and make the effort to make sure that is annotated as a right or a left. Okay. Hope that makes sense, guys. Okay, let's go on to another one. Forearm. Now we've talked fingers, hand, wrist, forearm are hung from the fingers. Okay. So our image pops up, the one on the left, and it's going sideways. Okay. That's not anatomically correct at this point, okay? And we know that we've done a right forearm, right? So we're going to take and we're going to turn that image up so the fingers are up, right? Now, we know that the thumb side is your radius, okay? Your pinky side is your ulna, right? So we can look at that distal forearm right there and we can see which one the ulna and which one the radius is. Okay, now we turn that image up. Now, how do we want that to look? Okay, we want that to look straight up and down, but we want the right to be on the right and the left to be on the left. And actually, you know, I'm sorry, but I made a mistake. So this one is not correct. This one is actually turned backwards. So it's going to sit in front of you in an anatomic position. So the thumb needs to be on the right side. So that image has to be flipped to be anatomically correct. Okay, sorry about that, guys. And if I could flip that image, I sure would. I can't. Hey, let's move on to an elbow. Just remember, fingers, hand, wrist, forearm hung from the fingers, right? Okay, so here is a elbow. So we talked about shoulder, humerus, and elbow are hung from the shoulder, right? So our first image comes up, and it's upside down because the humerus is pointed down and the radius and ulnar are pointed up. Okay, and we think to ourselves, okay, it needs to be hung from the humerus. So we know that the humerus needs to come from the shoulder down, right? Okay, so this is a left elbow, and you can see right here the head of the radius right here. You always know the ulna because the ulna comes around the humerus and goes into the olecranon process right there. But we know the radius side is the short and it's got a head on it. So we know that this is the radius side. And you look down to my radius side, which side is my thumb on? It's on the radius side. So the thumb is on this side. If you think about it in an anatomical position, that is absolutely correct because the thumb is on the outside and the pinky's on the inside. Okay, and it's marked with a nail. This is all about hanging protocols. Don't get too confused about this. Okay, just remember that your elbow is hung from the humerus. Okay. Let's see shoulder. We talked about shoulder. So we've got a right shoulder here, and they're both rights. You look at the skeleton, dude. Is that a right shoulder? It is. That's a right shoulder looking at me. So what's wrong with this picture? Okay, and I'll give you a hint. It just doesn't have a right marker on it, right? So if we don't have a right marker on there, the radiologist is gonna question whether that's a right or left marker. It's annotated as a right shoulder, but is it? You know, that radiologist isn't in the room with us taking the picture, so he doesn't know whether that's a left or right. So anyway, put your marker on there. Make sure there's a marker on there post-processing. And we see that the shoulder is actually hung from the shoulder. It actually looks like a shoulder of that skeleton, dude. Okay. Okay. This is a chest X-ray, and this is the importance of putting your markers on there before you take the image. So this one on the left, it's called situs inversus. It's when your organs are arranged on the other side of the body. So we take this image, it comes up like this. We don't put a marker on it. We're going to flip that image if there's no marker there. There is. They save their bacon by putting a marker on there. So we can actually diagnose that this person has situs inversus because of the left marker. Now, if that marker wasn't there, you would look at this image and you would turn that so it looks correct, hard on the left side. And that's a mixed diagnosis, okay? They luckily put a marker on here. And we don't want to misdiagnose like that, especially with chest x-rays. Try your hardest to put those markers on there. So if this ever comes up, your picture comes up and it looks backwards, but your marker isn't, maybe the patient's got something going on. And they deserve to know that's why they're here. So anyway, this is a good teaching thing right here. About using your markers, okay? Now let's talk about the correct chest x-ray, how it should look at you. Skeleton dude is staring at you. So picture's staring at me. Is his heart on the left side? Yes, it is. Is it marked on the right side? Yes, it is. So that's correct. Okay. Anyway, good deal. Use your markers so we can prevent something from happening and get you out of a bind. Okay, so pelvis, here's another instance where there just wasn't a marker used. You take that picture and it comes up like this, but you really have no way of knowing whether that's a left or a right. Imaging systems sometimes will do that. They'll come up and your image will be backwards. That's why it's so important that we put that right marker on there, because if we don't know which one is right and which one is left. Okay, another instance where you need to use your marker. Okay, this one on the right's good. It's got the right marker on there, so we know that that's the right. And that skeleton guy is looking at us, and we look at that picture looking back at us. Is that correct? Yes, it's anatomically correct. The patient's right hip is on his right side. Okay. All right, toes, feet. Remember on our hanging protocols that our toes are up, right? So here we've got an incorrect. It's marked really nicely, good job. However, this image needed to be flipped up, so the toes are up, okay? Here's the correct one on the right, okay? We look at our foot down there and we look at our image. Does that look right? My big toe is on my left, my little toe is on my right, and that is my right foot. So that is anatomically correct, okay? Where the one on the left is upside down, okay? Good job with the marker, however. Okay, in an ankle. Now we learned that ankles are hung from the hip down, okay? So this is a picture actually taken in IF, and it's a nice ankle. Good job. But it's hung upside down, okay? We know that ankles need to be hung from the hip. So we move over, we flip that image around, right? And this is what it's supposed to look like on the right, okay? Hung from the hip, right? All the way down to the ankle. And we know that the little bone, the fibula is on the outside of our leg, and the tibia is on the inside of our leg. So we look down at our leg, or we look at our skeleton guy, his fibula is on the outside where his tibia is on the inside, and that is his right ankle. Yeah, I hope that makes sense to you guys. Just make sure things are hung correctly. Okay, here's one more. This is a knee x-ray, and this one was taken in one of our clinics. I don't know where, but you can note that it came up upside down, right? We've got the femur going down right here. And we've got the proximal tib fib going up. We know that femur or knees need to be hung from the hip. So we've got our femur up and our tib fib down, okay? And we know that the fibula is on the outside, tibia is on the inside, right here, and it's marked with an R, okay? So looking at us, looking at the skeleton, looking at that image, we know that that's the right knee. We look at the one on the left, we can see that something's not quite right, and it's just upside down, okay? All right. Hey, very good. We're almost done here, I promise. Okay, here's some L-spine x-rays. These were actually both taken in our clinics. So very, very nice. That one on the right is a thing of beauty. Collimated very well. It's a nice picture. The one on the left is a nice picture as well. A little bit of motion there. You can see some unsteadiness there where there's some blurriness. But the reason I put this on there is because there was no marker again, okay? Now, looking at it, we don't know what side's right and which one's left. The 90% of the time, the image is going to be correct, okay? It is going to be what it is. If we'd have used a marker either left or right, we would know if that was correct or not, okay? So post-processing, we could put it right on the right side or left on the left side, but we're really not sure. So big bones like this, extremities you can get away with pretty well. abdomens, pelvis, any spine. It's going to be hard on that AP view to tell which side's right and which one's left. So strive to use your markers. Okay. Good job on those images, guys. Whoever did them. Anyway, that's all I got today. I am sorry if any of that come across confusing. That definitely wasn't my intention. However, just look at that. Get you a skeleton guy and put him by your machine and try to make your x-ray look like skeleton dude looking at you. Okay, except for fingers and feet. And they're a little bit different just because the fingers are up and the toes are up. Okay. Anyway, please reach out if you have any questions. Try and remember some of these things that we discussed today, quantum model, what that is, and everything to do with identification and evaluation. Make sure that information is getting put on each image that you do, and make sure you're using your markers right or left. And then post-processing using markers upright or anything like that. Okay. Here. Anyway, thanks for coming today. Next week, we're going to start diving into image critique a little bit, and it's going to be good. We're going to start looking at what images are supposed to look like and what to look for on images that you take, and knowing whether you need to retake that image or not, or change the contrast or density of an image. Anyway, thank you guys so much for being here. I appreciate it more than you ever know. And I hope you guys have a great weekend. We'll see you later.